that worked really hard to put this program together and coordinate with many people. Our newest volunteer is Maha Gu. Maha, this is Maha, and Maha has been communicating with a number of doctors, and she is a pre-med student that we hope to be a future cardiologist, inspired by all doctors in the American Heart Association. And then there's Ahmed. Where is Ahmed? Ahmed, thank you also for contributing to the administrative and technology part. And Ahmed has a friend also participating. We will have dinner started in about 20 minutes, and we would like to have you enjoy your dinner while the speakers present. Just like every year when we have SHAPE event, majority of our viewers are online. So we have a GoToMeeting currently running, and the meeting is being recorded multiple levels, I think both by GoToMeeting as well as by cameras. And our goal is to spread the knowledge and whatever is being discussed here. There is a microphone for everybody who is going to have a question or participate in discussions. So please wait till the microphone comes to you, because folks who are online would not hear you if you speak, and so for that reason. Last year, if you recall, we briefly introduced this project of focusing on cardiovascular risk assessment in short term, machine learning vulnerable patient symposium. That was the first one. This is the second one, continue of the same thing. But let's start with the end, which is usually we forget when we get into a lot of the details. That what are we about? Our organization, SHAPE organization, and I'm sure pretty much everybody who's putting sweat in this field wants to see this, heart attack to be eradicated, and many productive life years that are being lost to unpredicted coronary events to be saved. That's really what everybody takes pride in making that happen. So with that being our goal, we want to know where we are. And I'd like to get a little bit of interaction with the audience. And the key thing for everybody is we're trying to reduce events. We're trying to reduce mortality and morbidity due to cardiovascular disease. That's our field. But let's just ask a simple question. Who can tell me how many people died in the United States last year? Feel free just to give your best guess. How many people died in the United States last year? Any idea? I have the answer right here. It's one click away. But feel free to do a wild guess. How many people died in the United States last year? Anybody wants to take a guess?
5 million.
Okay, yes, 2 million. That number is close. Let's see where. Sorry, can we get this slide running? 2,626,418 people died last year in the United States. How many of them were cardiac related due to heart disease categories? Good point. So obviously we know the percentages, so we could do a quick math. And so 614,000 due to heart disease and 133,000 due to stroke. So a total of 747,000 equal to 28.5%. I have a point to make. It is sort of my key issue versus cancer, is that when you look at cancer, there are 10, if not hundreds of pathologies, different pathologies that you have to deal with, that you have to, put your efforts on: detection, verification, genetic profiling, and all that. But in our field, in cardiovascular disease, we only have one pathology, and that's atherosclerosis. And it's not really as complicated as cancer and all the things that are going through cancer. So drawing this contrast and analogy helps us to focus, if we were the policymakers, on where to put the money to get the best bang for your buck. So the nature of coronary artery disease and cardiovascular in general being an unpredicted, even in cancer, if you find a tumor, you still have a few months to do something about it, to write your will. In coronary artery disease, about 40 to 50% of the time, we only have 1 hour. Our patients die before they reach hospital. So that makes it even more important to have a focus on early detection, and later we'll say why short-term prediction is important. So these slides are not new to most of you, so I'm not going to spend a lot of time, but I'm going to really emphasize that if atherosclerosis become a national focus for early detection and treatment, detection doesn't save anybody's life unless it does something that people change their things. Either they call 911 faster, or they take preventive medications and change lifestyle, or whatever else that can prevent the event. But if those two couple together, there is a potential that life expectancy can increase. We're talking about the United States, obviously the same thing can be extrapolated to the rest of the world, by over 10 years. And it's all based on focusing on one pathology, atherosclerosis, early detection and treatment. So how do we get there? A heart attack-free future. I would like to draw an analogy. This analogy that's, we had discussions that shape for a heart attack versus a hurricane. Many of us in the past 3 months in Texas, particularly in Houston, really experienced nature. And of course those people in Miami with Irma. But Harvey really created a mess that if, when I was preparing for this talk, I had not known the magnitude of problem that occurred in Texas, in Galveston, 100 years ago with the Great Hurricane. So that's why I wanted to draw this analogy. But before we go to those slides, so imagine if the weatherman says there is a 7.5% chance of a Category 5 hurricane in the next 10 years. You think people would do anything about it? In next 10 years, there's going to be a Category 5 hurricane. They're not going to go shore up their windows, not going to go get more water or take immediate preventive actions. Vice versa, if coronary events and the stroke were predicted the same way as Harvey and Irma, and before that Sandy, which was a big mess, and the storm that we had in 2016, if they were predicted like we predict coronary artery disease, a 10-year prediction or a lifetime prediction. So this analogy would become a lot more drastic, because we don't see hundreds of thousands of deaths because of those hurricanes anymore, but we used to. This is an example. About 100 some thousand people died in the Great Hurricane, which hit the Galveston area in the south of Texas. And you just look at some of these pictures and you compare it to what you have today, and how devastation Of course, that was not just a building and stuff, it was people and their life. You can see people are all dead on the street. So this contrast should tell us that the advancements that were made in prediction of weather and alerting people to take preventive actions in the near future did save a lot of life. Whether we're able to do the same for atherosclerotic related cardiovascular disease or events, obviously it's a big question, but the analogy allows us to stretch our brain and our thinking that we can go beyond a 10-year risk or lifetime risk and try to identify people who are going to have an event in the near future. So how do we go about it? Obviously, when we have the ASCVD, atherosclerotic cardiovascular disease risk equation, which is relatively new, focuses on 10-year risk and lifetime risk. And lifetime risk only for people that are between 20 to 60 or 59, and the intention is to raise their awareness. That's great. You can raise awareness. But this is what we have done in the past 30, 40 years. American Heart Association really spent all of its efforts on raising awareness. Has it worked, or how much has it worked? Really, it's under question. Definitely there is value in primary prevention. There is significant value in population-based strategies that are reducing, but we left a big gap in short-term prediction and identifying people who are at risk. So what have we done in SHAPE? We raised significant awareness on the concept of vulnerable plaque and vulnerable patient. As you probably have seen some of our publications and participated in those, we raised this concept that we have to start from the bottom of the pyramid all the way to the top of the pyramid. We put together the first guidelines that was put together by, really, we didn't have evidence. We still don't have the kind of evidence that we would like to have, a trial-based evidence, an interventional trial. But we put together what we call SHAPE guideline. The general concept was that we should go beyond risk factors, which is on the right side, and we'll look at the disease itself, a structural part of the disease and the functional part of the disease. The structural part of the disease had the most data, which is coronary calcium, and the presence of calcification in coronary arteries became our first focus and the most supported by evidence, and that became part of the SHAPE guidelines. And this was the writing committee of our task force, and the algorithm, as you can see, has some component of cost effectiveness, and that is individuals over 75 who really cannot justify doing testing because of the cost effectiveness issues. And then individuals that are very low risk, like very young individuals, and by sort of general assessment are excluded, but the rest, pretty much the bulk, will go to get tested for atherosclerosis regardless of their risk factors. If they're positive for atherosclerosis, which is coronary calcium, then we want to know how much they have. And this was a big shift for me because I was focusing all the time on vulnerable plaque. Now we're talking about vulnerable patient. In vulnerable plaque studies, we always thought a calcified plaque was a stable plaque, or a plaque that becomes calcified from a fibrotic or fibroateroma. It's a good thing. But what we didn't realize that neighbor to the same plaque that is being calcified, there are other plaques that are soft or rupture-prone plaque. So the whole issue is we're going after the vulnerable patient, not vulnerable plaque, and calcification is a marker of vulnerability of the patient. So this is the status quo versus SHAPE guideline. Again, the notion of putting this into trials is still on the table. It's a huge expense, probably close to 100 million, to show that a screening for atherosclerosis saves lives more than a screening for risk factors. But that's the approach that we put forward. We did cost-effective analysis, showed about 21 billion saved over 10 years. And so come back to the heart attack versus hurricane analogy. Bottom line, long-term predictions do not trigger immediate preventive actions. Preventive actions that would make an immediate impact. So we need to have, well, we should keep our long-term predictions. We should do all the policy for population-based interventions, but we need short-term. How short? Ideally, 6 months to a year. So when a patient comes to a physician's office, we could tell them with significant certainty, not 7.5% over 10 years, a significant certainty, perhaps 20, 30% per year certainty that would shake them and open the way. Obviously, having such a marker, such a predictor, would allow us to do trials with a short time span, because 20, 30% is significantly high, and having trials to test one versus the other. In the process of this, we've raised awareness on the 3 components of vulnerability: the vulnerable plaque, the vulnerable blood, and the vulnerable myocardium. Each contribute differently to the whole concept of vulnerable patient. And so the most recent things that we have done, again, I'm answering the question, what have we done in SHAPE, is the machine learning project and the whole wave in how to bring machine learning and artificial intelligence to early detection. When we started early days, we were very obsessed with vulnerable plaque only, and we thought if we stop vulnerable plaque, we could prevent events. Soon we realized there are more than vulnerable plaque, and so we broadened into vulnerable patient. In the interest of time, I'm just going to skip the video and just briefly remind everybody what the big idea is. The big idea is developing an artificial intelligence-based forecast system for prediction of CVD events or coronary events or heart attack within 12 months. How do we do that? We go around the world to all these major cohorts that are available already. They have blood samples, and we want to look at those people who came to give a blood sample as part of their routine exam, either baseline or follow-up exam, and they gave their blood sample, they did their physical exam, they did their measurement and so on, they left the office the day after, a week after, a few months after, they had an event. Either drop dead or any kind of atherosclerotic event. Those people, we consider them vulnerable patients because they had an event within a year or 6 months, and their stored biospecimens, whatever it is, mostly serum or plasma, would have valuable information about what is going on prior to the event and how close to the event. So that's the whole concept of this project. We have talked to a number of potential funding sources, and we are still in discussions. This is really what it all boils down. Everybody said it's a great idea, so what are you waiting for? We're waiting for the money to be able to take this project off the ground. So now let's shift it to the topic of our symposium. I actually specifically wrote that the question is when, not if, super intelligent machines will replace cardiologists, and in what areas. So I'd like to just share with you a video, which I think will be entertaining. Let's go through here.
This is fun. I've been researching the internet. I found a few groundbreaking news reports that came out recently. These could change the face of medicine, literally. So it makes me wonder if maybe someday us doctors will be obsolete. So let's take a look at this first breaking med report I found online.
Would you let a robot draw your blood? Meet VBot, a robot actually being developed to take the guesswork out of drawing blood. VBot uses infrared light and ultrasound technology to identify the optimal vein below the skin. VBot currently holds an 83% success rate, but Epson, which manufactures some of the fastest and most accurate multi-axis arms in the business, feels confident that if it can gain human trust, We may be making our next appointment with this robot soon.
Okay, that was just for fun. I will not let the robot draw my blood, not yet. But this actually is a project. Epson, is a big company, printing company, and all these automation companies with automation technologies are getting into this. So the question that I raised, which will be discussed tonight in several ways by presenters and so on, is that there is no doubt. The answer is absolutely yes. The question is in what area and how soon. So we were discussing one of the areas that cardiology may see a massive revolution. It would be turning echocardiography to something like the self-driving car, autonomous car that we hear many places are working on in Silicon Valley. An autonomous echocardiography machine that does the entire routine echo exam without you having to touch anything, and does the results and reports and everything as you do now, and give to you, either you're a cardiologist or internal medicine or a family physician. That's one of my predictions. And there is a saying that the best way to predict the future is to build it. I'm actually collaborating with a group on this project. I know of other people are doing a similar approach to other imaging modalities. So the short answer to this is what areas is any area in cardiology where automation is possible, it will be possible. It will happen. Whatever it is that, the robotic surgeries and all the remote things have been around for a while, but in our field, it may not be next 5 years, but we're talking about, say, a 10 to 15 or 20-year spectrum. Very intelligent machines, very intelligent readers can do a lot of those things that we currently do. Now, we all know the pioneering work that IBM did with its Watson machine in Jeopardy, and similarly the pioneering work that Google did with beating the Go champion of the world. All of those come down to this, that we are experiencing a shift. Our shift may not be as fast or maybe faster, we really don't know, as the automobile industry or other industries that are experiencing the presence of artificial intelligence. But as pioneers, as researchers, as practitioners, we have to be prepared and open and possibly contribute to this development. With that introduction, I also would like to add that I met with Dr. Fuster this morning. He apologized that he couldn't join. It was last minute, some other events took his time. So with that introduction, I'd like to turn the meeting to our moderators. Dr. Matthew Budoff and Dr. Berman are going to chair the sessions. Matt has been with SHAPE since SHAPE was born, and his contribution been very central to development of SHAPE guidelines, and a lot of discussions that we will have as we go down the presentations, and each of these presentations will come in. So Matt, do you have your microphone with you?
Why don't you Peter first? So we're moderating.
And so
Joe Slomka is the senior scientist at Cedars-Sinai Medical Center, where he has been applying machine learning algorithms for several years now, and I think has taken the imaging field to a really new and exciting level. So, yeah.
Thank you, Glenn. I would like to add that along with Dr. Budoff is Dr. Daniel Berman, who is the pioneer in nuclear cardiology, now in CT and CTA. He is also one of the many legs of shape and leaders. So thank you for joining and for moderating our session. Your turn.